morning.
Good morning.
I'm going to go ahead and formally initiate our New Mexico Department of Health Facilities and Los Lunas Community Program Governing Board, which is now a quarterly meeting. We'll talk a bit more about that this morning. And hopefully, if we all can talk, I'll try to talk louder as well. We may have some people calling in today, or not calling in, but participating through the webcast. I know Tomas from the Education Department wanted to try to do that. And I think our LFC reps, Ruby Ann and Pam, may also be doing that, as well as anybody else from the public. So I'll try to talk a little bit louder. Maybe we can all do that if we're giving our reports. And Kathy also will be taking any emails if we get some. You know, one of these days that'll happen, I know. And
Ruby Ann just emailed that.
oh, there you
She
go.
said, have a good meeting. She's in another meeting.
All right. Okay, thank you. That's correct. That's correct. Let me I'll talk to you about that later too. That sounds good. So let me call to order. The first order of business would be to establish a quorum. So I think, Kathy, for your benefit, we'll go around the room, starting to my right, and we'll just do our roll call, okay? And I'll start with Secretary Ward.
Retta Ward, Aging and Long-Term Services.
Louis Trujillo with Clinical Performance for Department of Health.
Gail Nash, Chief Nursing Officer.
Richard Adams, Chief Medical Officer.
Anita Westbrook, Sequoia.
Troy Jones, NMDOH.
Rick Spina, Administrative Services. Michael Gutierrez, Turquoise Black Rock.
Zachary Hopkins, Children and Families Department.
Kathy Thompson, Office of Facilities Management.
Janie Davies, New Mexico Rehab Center.
John Helligas, Los Lunas.
Donna Deason, Fort Berry Medical Center.
Lori Montgomery, New Mexico State Veterans Home.
Tim Hale, New Mexico Department of Veteran Services.
And Brad McGrath, Interim Secretary of DOH. And thank you. We have a quorum. And I can't tell, I guess, Kathy, I can't tell if Tomas or somebody is participating unless he emails us or something.
Unless he emails it.
But he may also be participating today. He's going to attempt to anyways. And then just some quick items here. The approval of the agenda. The agenda is basically the same agenda as we normally have. However, I'll encourage us to have a little more open discussion, I think, you know, for the benefit of all the board members today. I think so that than we normally have had in the past. And we can look at our administrator reports and also see if there's opportunities to, you know, maybe add a little bit more to those. But the first item of business would be approval of the agenda. So I'd like to request a motion to approve the agenda.
I so move.
Second? Second. Okay, all in favor?
Aye.
Opposed? Fortunately, nobody's ever opposed the agenda yet. And then also, we've got 4 sets of minutes. I'll guide you through that. We're going to a quarterly format, and with credentialing, is we're trying to get we'll have a bigger discussion about credentialing today. We're trying to get that committee, we're making some changes to it in terms of the membership on it. But when you have quarterly, with credentialing, periodically there's a need where our providers is expiring in terms of recredentialing, and we have to have an emergency session for 10 minutes or so to do that. So in addition to October 18th, 2012 minutes, which are in the front here, that was our last quarterly meeting. If we would look at those for a moment. The ones on November 1, 15th, January 3rd, are behind, or a little bit further back in the packet, behind the October 18th minutes. Kathy was saying she's got the administrator reports from last time, from October 18th, and behind that would be the minutes from those emergency ones, I think, Kathy, right?
Yes, November 1st, 15th, and January 3rd.
And all 3 of those were for one specific purpose of doing some
Emergency
credentialing.
credentialing.
for
Those are on
providers.
pages 15 to 19.
So a big chunk of the book there, but probably the more important one would be the minutes from October 18th, which is from our last quarterly meeting. Which was actually the meeting we decided, I know we discussed about going quarterly. So that was a motion we made at the October 18th meeting.
need a motion to accept them all in mass, or do you have to do a motion for each one though?
I think I can make a motion to accept them as a group.
I'll make that motion.
Okay, yeah. Second, all in favor of approving the 4 sets of minutes?
Aye.
Okay, all opposed? Anyone opposed? Okay, motion passes unanimously, thank you. The new business reports, we'll start having a discussion now. I guess as an interim secretary, Gabrielle, my chief legal counsel, had to go to a meeting at the governor's office this morning that we just called regarding DD waiver. We're meeting with HSD, Secretary Squire and her team and our team, and we're just making some adjustments there to implementation dates. So she had to go to that meeting. The only thing she asked me to talk about in my report, which I'll do in a moment, will be, I think, again, we talked about it a little bit last time, voting members. And the only thing she had a question or concern about was, as we do credentialing to protect our non-DOH governing board members, when we do credentialing, it's a very remote possibility, but, I think in terms of, you have a provider later on, or there's issues with that provider, or there's litigation, and the governing board voted on that particular individual, that she felt that it would be better if the non-DOH board members were not voting members, because then they wouldn't have to vote on those types of issues in case there was some, you're protected as governing board members, but she just felt that that was a little better. You wouldn't be as knowledgeable about those providers as we would be, working in the facilities. So that was her thought on that, so that you wouldn't be in a situation where you had to vote on that. And I think somebody had asked us that question too, on the board. So that was, I think, what she was recommending. I know we keep talking about voting and non-voting members, but I know all the administrators, by necessity, are voting members, and the CMO, I believe, is a voting member, and the CNO, now we have a CNO with Gail Nash, is a voting member, and myself, and I know Secretary Hal has been a voting member, and you can continue to be that. It's just, I think that was Gabrielle's suggestion as legal counsel, that as we go in to have those discussions in closed session or something about credentialing, or issues with providers, or disciplinary actions, you wouldn't have to feel you were involved in that, or getting pulled into that a little bit, when you, so I think she was doing that for your protection. So if that was amenable to the, hi Greg, if that was amenable to the governing board members that are not with DOH, to be a non-voting member, I think that was the one thing she would want to bring up today if she was here.
I'm fine with that.
You're fine with that. That would include Tomas as well, if he was here. So it doesn't change anything in terms of what we're doing here and everything, and participation, and just on that one issue of credentialing, it's more protected. So, all right. Morning, Greg. I know I was just saying that Gabrielle is in a meeting on DD waiver this morning, and appreciate you stopping by and filling in for us. Appreciate that very much. And we were just talking briefly about the membership. Gabrielle just wanted to suggest, and I think we're agreeing on that. We can vote on that in a moment. But in terms of, she's trying to tighten up the bylaws in terms of voting members and non-voting members.
Yes.
And then decide in terms of credentialing, it's just safer for the non-DOH governing board members if they don't have to have the burden of being involved in that and voting, or being involved in discussions of issues with providers or credentialing issues. So she recommended that they be non-voting members in terms of that. So
That makes sense too.
And so maybe I'll just request a motion in terms of our membership, that each of the administrators, myself, the CMO, the CNO, will be the voting members of the governing board, and the remaining members on the governing board would be non-voting members, or ex officio members, in terms of voting.
So moved.
Have a second? All in favor?
Aye.
Okay, all opposed? Okay, thank you very much. And I think we also had talked about last time, which I think will work better, especially with the legislative session coming up now, that we talked about going quarterly, trying to make the meetings more, I think, meaningful in terms of our discussion. There's certain things you do have to still discuss in closed session, like disciplinary matters, which are as it would be in any state agency. If you're having a disciplinary issue, you need to discuss those confidentially, or an issue with a provider. But try to be, a little more, I think, have a little more interactive discussion in terms of the open session in the board meeting. So we'll start trying to do more of that today. And with quarterly, that allows us to by not meeting monthly, besides the logistics of getting to a meeting, with the legislative session coming up, we would not have to meet again until April. We were rotating through the facilities, and there's a lot of value in doing that occasionally as well. I think Fort Bayard, for instance, we always want to go to Fort Bayard. We never get there. So, right now, we can discuss as a board, where we want to have the meetings. But I know the farther away we go from Santa Fe, the harder it is for people to get there. For instance, Fort Bayard. But on the other hand, it's nice to at least occasionally see some of the facilities. Whether it be here in Albuquerque or Las Vegas, where there's Roswell, there's, Truth or Consequences, there's Fort Bayard. So we can talk about, the pros and cons of doing that. I know we have had the chance to do that. We have been to some of the facilities here. We've been to Turquoise, and we've been to Sequoia in Las Vegas, and we've been to Los Lunas. And I think that was very educational to do that. The Veterans Home is beautiful. It's a beautiful facility to see. So that, maybe not in the middle of the winter, but it would be nice. I think, I guess I encourage us to look at maybe those opportunities periodically as we go forward. We're not locked into any one particular place, but you can learn a lot by seeing a facility and getting a tour of the facility. I know Secretary of Health is very familiar with the Veterans Home, but a lot of you haven't had the chance to do that. So, we can look at that as well. I think in the April meeting, I hadn't given that any thought yet. I guess we'll see how we feel after the end of the legislative session and how much energy people have for going anywhere at that time. They're not all on vacation or something.
Hot Springs.
Right. That's right. And, okay. And I appreciate everybody just being here. I know everybody's got really, really busy schedules. I serve on a lot of other boards now too, and I know they're just appreciative when I show up to their meetings. So I know how important it is for you to appreciate it when you show up at our meetings too. I really appreciate that very much. So we want to make it educational more, I think, especially for the non-DOH members, so that you learn more, I think, about the facilities. I think that's really helpful to you as well. So along that line, as we go into the administrator reports, which Troy, I guess, is way back there on page 20, I think. And I think, Troy, I know you have it in here, but it's always interesting to hear as you're going through that, a little bit more about your projects there. As you're expanding your Meadows project. And I know the norovirus is something that's been plaguing the whole state.
We've been free, no staff or patients or residents for 7 days now.
The whole state has had a real outbreak of that, but I know I'm interrupting your presentation, but
You can get that.
no, that's okay. No,
I prefer that.
well, we're looking forward to hearing from you there. So why don't you go ahead and then we'll just ask you some questions.
Okay, I'll jump into our census. Right there on the top, our adult psychiatric division had 170 admissions during this quarter, 183 discharges. I did not have the average daily census at the time the report was done, but I do now for Ruby Ann, so she can have it in a minute. Our average daily census for APD was 86. On our adolescent sex offender unit, we had 4 admissions, 3 discharges, average census of 8. Forensics division, we had 40 admissions, 41 discharges, average census of 76. Out in our outpatient program, we had 134 new admissions. They're running a census of a little over 1,500. In long-term care, we had 11 admissions, 8 discharges, 5 of which were deaths, which are average census of 148. As you were saying, Brad, on our projects and constructions, Meadows Phase 2 is well underway. They've already poured a lot of the foundation, and it's moving along really quickly. So far, they haven't hit any new problems, and we're expecting that to stay on schedule. They're actually, I think it's February of 2014 or March of 2014 is the deadline to have it completed, but if they continue on the schedule they're on now, we may actually have it done by the end of this calendar year.
Just remind everybody too, because you've got so many different functions up there. That's your long-term care area.
Right, it's gonna be our new nursing home. We have currently, phase one is completed, residents are in there. It's got a total of 36 beds in phase one with all the, I think some of you took a tour of that last time, with all the main pieces like our cooling, electrical, computers, that's all completed. So now phase two is 72 beds. Phase three, we're going in, asking the session, this session, for some monies to do construction drawings and to demolish our old nursing home, which is right next to it, one of our nursing homes, which is right next to that, build up the ground to where it's ready. We have the construction drawings in place to ask for the next session for the money. So if everything falls into place like it should be a continual process from here on out to get phase three done, which is an additional 72 beds, total of 180 licensed beds there. So looking forward to it. It's really it's beautiful. It's like a home, and everyone wants their office there. But everyone's trying to move, so it's really nice. Another big project we have that's going to be completed at the end of this month is our forensic salad board. That is turning out to be a really nice area, very secure, where individuals come in and they're actually processed before they go into the main building. As it is now, they come in, they're in the main building, then we go through the process and they're already on the units. This will give us a space that's more secure, safe to allow that to happen.
I know, Troy, we've had a lot of discussions about that again for our non-DOH board members with forensics. What we call 1.5s has been a big problem for us statutorily. We have this requirement, this duty, and then 30 days, I think, right?
Well, if they're found 1.5,
not competent to stand trial.
They're not competent, they're not restorable, and yet they're dangerous. And the court can then commit them, and I forget the actual term, it's not a commitment, but they assign them to us for what would have been the duration of their term had they gone through the court process and been found guilty. So we have people in there for 5 life terms, some are, a year, they vary. We have 2 new ones coming in today, 1.5s, and I got another one scheduled next week to come in. So it's going to put our census of just the 1.5s in that forensic main up to about 49% of our beds are being occupied by people who could be there for 5 life terms. So we have them, in fact, we're seeing a transition on some of them. The court, they get so elderly and frail, the court will actually drop the charges and we move them to a nursing home. We just had that happen to 2 of them.
One of the things we were talking about, we had a very good discussion with Legislative Finance Committee about is long-term, whether there's a need for a second one in the southern part of the state or a second one or a larger one on your campus in the back of the campus. Because they don't tend to leave, they come but they don't go. We're rapidly outgrowing that, yet we have the statutory requirement to do it. So it's a lot of money to do so, and then nobody really, and there's not a lot of communities that want that in their community. So it's, but at least the dialogue is beginning about whether there should be a second one also in the southern part of the state, or whether you just need a much larger one in the back of your campus. We're looking at different options.
Right, we gave recommendations, I think, because we have sex offenders, adult sex offenders that are under the forensic division. We have the 1.5s, and then you have the other statutory requirement is that we assess for competency and treat the competency. And so if you're going to build another one, have it specified for either just one of those populations. The 1.5s all go here. The treat the competency, assess the competency are done here. Sex offenders are done here. So that way you don't have, I guess, a hodgepodge of different services going on in one building. You're focused on one main mission. We are looking at our STOP program, and actually the cameras are going in this week for us to be able to move some of the forensic main population over to the 24-bed unit over there. We've already set up the Carcentino wire and the fencing so they're separate, and the cameras, like I said, are going in this week.
Our STOP programming is our sex offender unit, so we need some of that space, but we need to segregate the populations.
And it's in almost complete.
Right.
We're looking at even possibly moving those individuals in next week if our environmental care department gives us a grant.
Yeah, it's a very large, complex campus up there, and they have at least 5 different types of populations that we serve up there. The one I was always familiar with as a hospital CEO, but I was naive. I thought that was the only population up there was the adult psychiatric. So in Roswell or Carlsbad, we'd always be trying to transfer a patient. They'd say transfer somebody to Las Vegas, and then I thought, well, that's what Las Vegas was, adult psychiatric, and it is. It's a huge part of what you do, but it's a much larger campus than that.
Yes. And it's confusing even for we have a new CEO coming into our local hospital, so we start the orientation and training all over again to explain the different levels, because if we send someone from our nursing home over to acute hospital, it's different than if we send someone from adult psych over. If they get admitted from our adult psychiatric division, we have to discharge them.
Right.
And if they're in forensics and they go to our acute hospital, we have to have security or personnel with them throughout the entire time because we're responsible for their safety. You try to explain that to a new CEO coming in, it doesn't always translate really easily.
Right.
And we have to learn from our mistakes.
I think that's Catherine Cahill.
Yeah.
And I know Maridell is replacing me, actually. You know, they haven't replaced me in 2 years down in Roswell. So she was my assistant. Now she's going to Roswell to replace me.
She was a great asset there. We actually have a good relationship. We meet with ALTSD once a month. And we got to the point where there were no problems. And they would call and say, do you have any issues? We'd say no. Like, okay, we don't need to have the meeting. That's how great. And we started weekly meetings because of some of the issues we were having when we first came on. And we're going to do that with the new CEO.
Oh, that's a good idea. Okay.
Another piece that last bullet there on the projects is in regards to our campus security. We received some capital monies for campus security. After the Connecticut incident, actually the day after, I sent an email to our Environment and Care Department telling them we needed to really focus on the security pieces, the low-hanging fruit things we could deal with right now on our campus to provide safety and security. It's such a wide-open campus that people could come in, create a lot of havoc by the time law enforcement got there to assist. So we have keyless entry on almost all of our buildings now through another capital project a few years ago. We're going to be locking all of our buildings that have that on it during the day also. So if you come in, you're a staff member, you can get in. You have access to that building. But all the public will have to come in through one door for admissions, for everything in the adult psych side. They have a camera already we put in place and have to be buzzed in to come into the building. So that's going to help with some of the safety. In our outpatient clinic, we're changing our protocol on our benzodiazepines. It's like narcotic medications. How we prescribe that and get everybody on the same page. And there's going to be a lot of really upset individuals when that happens. So we're really looking at the security out there closely to make sure when that change goes into effect, they can't just come into the building and have free reign. We had a patient the other day, he did not get his Xanax. The doc had canceled that. He moved somewhere else and he came back and wanted it. And went to the pharmacy, caused quite a commotion, and then went down the hallway into the prescriber's office where she had another patient and was threatening her that he needed his Xanax prescription. We haven't even changed the policy yet, so it's going to get, that's a sign that that's up on our radar pretty close. And of course, HR is going to be another piece. Disgruntled employees, when we have people that are terminated, they go to the HR office and go through that. So we're really looking at how we can secure our HR department. They're putting signs up saying, go to administration. I'm not sure what that means. They have a picture of mine of me there. Go talk to this guy. I'm not sure what that means, but we'll handle that. In regards to personnel, there's a number of 44 during the quarter. We still use locum tenens. We actually have some real stable locum tenens that are working out really well at the facility. I think our psychiatric department right now is probably one of the best groups of individuals. We consider them part of our department, some of the locums, but really high qualified, talented individuals.
This might be the best team you've had?
I think it is, absolutely. In my 16 years I've been there, I would say this is the best team that I've had. We have Dr. Krasowski, who's a contract employee, but she serves as our chief of psychiatry. Excellent. We just hired Dr. Collins from Corrections. He was there for 15 years in Corrections as our chief medical officer. We brought him on as our clinical director. He started Christmas Eve. That was the best present I could have for Christmas. And he's going to be a really good asset. I'm really glad to have him on board. So we're lucky in that regard. Dr. Santi Stevan is a psychologist we have that's going through the prescription process for psychologists, and he just recently took over as our adolescent sex offender director. He was the clinical coordinator of that program, which is required by licensing. Now he's actually serving as the director and the clinical coordinator of the program. So we're fortunate to have him. Our previous director was there in an interim basis for 3 years. He retired, did his 25, and got out. You talked about the norovirus. We had And actually, Office of Epidemiology came down and met with us. They did consider it an outbreak. I didn't like using that word, but that's the way they classified it, because we did have several cases. The majority of the cases were with our staff, and they were contracting that on the outside. They would come in. Our infection control nurse did an excellent job. Began tracking that with probably like the first case that we had came through. She went out and developed a tracking mechanism. And all these individuals were saying, my kids were sick, throwing up, diarrhea, and now I have it. And we would send them home. They couldn't be at work, and the recommendation was 3 days after their last episode of diarrhea or vomiting, they were still highly contagious. And so our staff we were able to do that, and now, like I said, 7 days without any active cases of staff or patients.
And that's been something that's been throughout the state and throughout the country. This has been a bad year for that. There's just been quite a bit. I guess the only good thing is that it doesn't last, 72 hours or so about?
Yeah, 1 to 4 days.
1 to 4 days. But if you're elderly, of course, and we have it in other facilities, if you're already fragile, then that can be very serious.
Dehydration
Be a very serious thing.
Absolutely. Office of Epidemiology was great, and so you can thank those individuals. They came out and gave us all kinds of recommendations. The important thing was to keep it out of our dietary. We had no instances of staff having the symptoms of dietary, and that was the big piece to make sure we did get it there, because if you get it there, it's going to be a bad thing. I tried to get them to have us stop admissions to our forensic program into adult psych, but they said they couldn't violate the law.
That didn't work.
I was thinking I'm the only hospital that begs for a stop on admission like that. The only other thing is the CPT codes. I understand that, while I know there's a change in CPT codes that went into effect January 1st, I understand that the 3 patches that IT needed to get those into our electronic medical record system they're in test mode right now. And so we dump our billing a month behind. So when we dump in February, we have to have the new codes in for the January.
Right.
But we're going to go in manually, do the crosswalk, do that, and hopefully then Avatar will be up and running.
I'm going to try to do 9 o'clock Friday morning, combined facility administrators and your HR and your CNOs, your finance people can all participate on the call in our senior management team. And I know one of the topics there, as a follow-up from last time, because Charles asked a question to Jeff Escobel and Terry, we'll talk about the CPT codes again and make sure that we're online doing all that.
It looks like it's heading in the right direction.
So that I encourage people too on that one on Friday mornings. Gail and I talked about that. CNOs are a critical component of your leadership team, and now we're getting some really good new CNOs as well. Gail is mentoring all of them, so that's really exciting. I know at Roswell, of course, we've got one from Fort Bayard is going to Roswell. She's got some experience, but Gail will be working with her, and I know at John you've got Ida now, brand new. One who's getting great reviews, and Sequoia's got somebody relatively new also who's doing great, and so I think as we're doing that, we want to just keep strengthening that mentoring process on the CNOs, but I think having them on the calls so that they can hear all the things we're talking about. We already have finance and administrators and HR, but that's kind of the engine where we get a lot done every week is those meetings, or every couple of weeks. So I encourage you to do that too, like with Frances, if she's available. Quality directors also, if you have one, they're always welcome to be on the call too. Okay. I guess with Troy, I know I've been asking a lot of questions, but does anybody have any questions they'd like to ask Troy?
I don't have a question at this point, but I'd be interested to know the impact of the CPT changes and some of is it in your outpatient, is it enabling your docs to spend more time with the patients, and some of those, that medium and high, is it medical decision making, or the intent of that was to provide outpatient psychiatrists with more time to deal with complicated cases. I'd be really curious to know what the impacts are, both positive and negative, financially and as well. Are you able to really spend more time with complicated patients, and is it making an impact clinically? And then financially, is it neutral? Is it costing
Yeah, that's
money?
a good question.
We're we're gonna track
really
that.
curious to know.
I know in the 90862, which is the medication management code, they modified that to have timeframes on it, so if you do spend more time, you can actually compensate for it. Before it was, you know, you do 15 minutes or an hour, it's the same
Yes, it wasn't a
reimbursable
time
rate,
based.
so I see that as a good thing.
I'm curious to know if those enhancements were neutralized with the way the Medicaid office did that. So I'm just kind of curious to know, is it enabling you to spend more time and are you able to cover your doc time or not?
And our
Because this
next,
is a really good change.
the next governing body meeting, I should be able to get you some information.
That would be awesome, because I'm really curious about it.
Because I'll hear about it if it's.
And you'll know financially if
I mean, if it's going well, I may not hear as much about it, if it's going bad.
It'd be great to hear that it's going well.
I agree.
Okay, yeah, that's a good question. All right, so no other questions for Troy. And with Anita, I'll ask you, there's some things that are, more confidential there. I know we're working on some issues there, but some is not as confidential. We can talk about it here. But I'll let you go through your report first.
Sure. The census is available per month. Capacity of course is 36, but we've been a little short on clinical staff, and so we've deliberately held it about 30, 31, 32. We have a couple of construction projects that we have been tracking for reports to the board, and we thought we were through, but they weren't. And so Carl Reed with Property Control is involved in these. One of them, apparently we've got some leaks on one of the roof above the boiler room, mechanical room. So he's working, Carl is in the building very often, and he'll be working with our staff to see if he can get warranty funding to cover that. And the second one is the fire riser project. We just finished that, and apparently with the fire marshal inspection, there was some additional work that they needed to do. And I'm guessing that it was omitted at the time they initially signed off on the project, because it's not flawed work, it's just something that wasn't done. So he's looking at obtaining some funding for that. Purchasing is still getting quotes. We've had some delays with people wanting to give us estimates on the security camera system to expand our coverage. Facility-wide, we really want to, our first priority are the common areas and the lodges. Second priority is going to be the courtyards, and then
Right.
moving on over to the gym. And so that's really an important thing for us. We don't have any spare cash right now either, but
Very, very important.
we're working on that to finish those quotes. We actually anticipate 2 more. We've had a series of special events. We try to do something every month for the kids that's special. And of course, the fall festival and trick-or-treating is the typical October thing. Our staff are quite generous at Sequoia, and they've stepped up a lot, which is when you haven't had a raise for years and years, and some of them, and everybody's aware of that in all the state positions, but they continue to give to the facility to provide for the kids. Thanksgiving, we've had a Thanksgiving dinner hosted every year. Each kid gets to invite up to 5 people. They come in, families come, they bring their siblings, we had grandparents. We had divorced spouses sucking it up for the benefit of the kid that was there sitting at the same table eating. And so we had some real good things, and we did a great job, and staff donated the food that covers the guests, so that we don't use any state funding for that. We had a really nice Christmas reception. We provided refreshments, invited everybody to come up to administration. All the kids got gifts. We had gifts given throughout really the 2 weeks before Christmas, a variety of different
That's great.
things. One of the things we're trying to do is to make their rooms more home-like. And so they've all gotten new sheets and a lot of throw pillows, and we're working on window coverings, et cetera, in addition to some of the refurbishing that's going on. And they all got to go to see the River of Light celebrate. Well, they didn't all go. Those who were okay to go out of the building got to go to that. And so they were appreciative. Every kid got at least 3 different Christmas gifts from the facility and staff, and through contributions and things. We were able to provide that as well.
I think it needed too, the average length of stay there is a long time, so all that type of outreach is really important, because they're kind of cut off, so to speak, from the outside world to a great degree. So making it feel more like a home is really important to me also, and it's not a correction environment.
Absolutely.
And the environment has always been, at least in my opinion, I know, is it in your opinion as well, a lot of us, it's been too sterile, and that's why we're trying to invest in trying to change the ambiance there, make it more, feel better, right?
Yes.
And make it feel more like a place where you live as opposed to being barren and sterile. So that's an ongoing project that we're working on real hard there. So those projects and the cameras are really important to make sure it's a safe environment.
Yeah. We're really focusing on reducing seclusion and restraint, and our
Right.
numbers are coming down. The use of mechanical restraints has dropped to almost nothing, which is way better. A lot of our kids struggled, not a lot, some of them struggled right before the holidays. And you can imagine, some of them have no family, they've been abandoned, neglected, etc. And so here they are, and holidays are particularly tough with them when they're the people that are in their community are having family visits and they have nobody. So they've struggled a little bit, but that's not unexpected for us. One of the things that we're planning we've got a lot of different strategies, and actually Gail and Louie have been in the facility. We're all working on moving the facility forward to be as progressive as possible and being therapeutic. And so we've had some conversations. We talked with staff, the all-staff meeting the other day, and the teachers and different kids are coming forward with suggestions. We are currently operating on a program where kids earn points, and they use those points to quote-unquote purchase things. And so we're talking about with them, and who better to tell us what's meaningful to them than the kids. And so they're coming forward with really some interesting ideas about things that would be important to them. For example, we would like to see, maybe we would like to be able to wear some jewelry. We can't do that right now. We would like to be able to have more time that we can meet with others from other lodges versus the people we're with. We would like to be able to have more games versus just shooting baskets. We would like to have basketball games. So, I mean, we're actually seeing some things come forward I think are really good for them, and what they're telling us would motivate them. So we're moving along with this.
And on that topic, I know all of us feel that way. I'm very passionate about this topic because, as much as possible, I want to see both a chemical and physical restraint, as much as possible, almost a free campus, where it'd be a very remote situation where we have to do either chemical or physical restraints. And I know Gail and Louie are working real closely with you and your psychiatrist team there and your clinicians to do that. And it's just something that, it's been one of our biggest accomplishments, I think. And we're already making major strides in doing so, and I appreciate all the work you guys are doing there and continuing to do. I think that's one of the most important things we do this year, is continue to make that an environment for those boys that, it feels like a place to live for them, right?
You bet, absolutely.
We feel like we're focusing on educating them and helping them be successful when they leave there, as opposed to just policing them, I think, right?
You bet, absolutely.
Right.
If I could ask, how much can a community group get involved with your facility? And where I'm coming from is, we have a lot of veteran groups where, especially if we're working with PTSD groups, one of the best things they can do is reach outside themselves. Is there an opportunity to have interaction, to have groups be designated and really link into your facility?
Yes. We have to, everybody that comes in, and the policy that we have had, and we've erred on the side of being very restrictive. And so we fingerprint almost everybody that comes in that has that there might be an occasion for them to be working with a group without somebody directly observing.
Right.
But that's not always necessary. We can have people come in. We have, for example, Narcotics Anonymous, Alcoholics Anonymous, other substance abuse groups. We have religious services. We have things of that nature. Well, we have Mountain Center folks, and so all of these people are coming in and out, and they're working with our kids, and that works
That would be
very, very
nice.
well.
That would be
so
great.
Yes, we have opportunities.
I'd welcome that too.
Okay. I'll talk to some of the veteran groups and see if we can't start working something like
I want
along
to
that line.
focus on when they leave there,
Right.
We want them to have a future.
Absolutely.
when they leave there. Sorry.
There's a lot of evidence that supports that kind of mentoring.
Right.
So that would be great. I just wanted to say that I really appreciate your commitment, your all's commitment. Dr. Davis has been meeting with the psychiatric staff up there and hearing good things, and really anticipate.
Yeah, I think you're coming back, or some of your folks are coming back tomorrow, right?
Yep, I'm gonna be there too tomorrow,
Tomorrow.
and really excited, because we really depend on Sequoia, because you guys take care of our most aggressive kids, and we need that lovely care
Right.
in our continuum, and you guys are the only ones that do it, so I want you to know I'm committed as well.
Oh, I know you are too. And I think, what we've tried to focus on, which CYFD gave us some good advice on, is there's always opportunities for better communication. I mean, hearing from the boys is really good, better handoffs, better, education and training of the staff as we go through these changes. For the staff, it's been a little bit challenging, and you might hear that, and sometimes there's been some disgruntled employees, so sometimes if there's a small number of disgruntled employees, they're very loud, and then the rest of the people are not. But it's hard for some of them. They were more comfortable in an environment where we did a lot of restraints because they felt they had, it was control. They felt safer or whatever. And so going to an environment where we don't want to do that, where the boys aren't chemically restrained or they're not physically restrained as often, we try to use more, other interactive ways of working through those issues with them. That's a change for some of them. So we're aware of that. We're working through that, and CYFD is helping us with that. But it's essential that we do that because, just keeping them restrained is not a good environment.
You probably have a lot of kids that have traumatic experiences and may have some trauma disorders, and so it's really important for those folks not to have a lot of restraint. So I really commend your efforts. I think they will pay off greatly for you.
Right.
One of our larger initiatives, as you move on through this report, the clinical staff report, Brenda Frink was hired in the 1st of October, and she's made several changes that I think are very positive. One of the changes that we've moved to is to bring in every month as a part of the treatment team, the people whose treatment plan is coming up. Those people are now actually invited physically to the meeting to be able, we've allotted more time, they can physically be there, or we can get them on the phone if we need to, if family lives somewhere else, and involve them in the treatment plan, get to talk to them directly, and the team, they're involved in the team. Before that was delegated out through the psychologist, which was a different way, and we feel like this is better to have them actually involved in that process, and so they get input. And we've moved clinical staff where we have a clinical staff person working every weekend now. That's a new thing, Willie's never worked before on the weekend, and so they rotate through each clinician, and they have to have, it winds up being, well, we have several clinicians with the psychologist, et cetera, so once every couple of months, maybe even every 10 weeks or so, they're having to work the weekend, which has been really fairly well received by those people. I think they recognize that they need to have some additional guidance as well. So we're working to pull those people back into, they have to attend the things that we call code chills or code backups when kids are struggling. We have to have the therapist respond, and so that we actually have that involvement, and that's a number one priority for us.
Right.
So we're changing some of those priorities. As you were talking about trauma, we have a multidisciplinary trauma-informed care committee that's now active. And so we're going through what that means to us, what it should look like, the things that we need to do to be providing care that is trauma-based, and it's based on a culture of safety, trust, and mutual respect. And so we've done the initial work with that, and we're
You'll
moving
get
forward
big
with that.
dividends with that, I think.
Yes.
It's a culture change.
It absolutely is a culture change.
It's simplistic, but when I talk with Gal and Louie, I say I'd much rather go in there. I want to go in and hug them, not restrain them.
Yeah.
They're boys,
Somebody's sons.
Yeah, they're just boys. So it's just, you want to see them be successful. So I think that would be very good. I mean, I think they need to have role models or people that are thinking about what do they do when they leave there, So I think that's great. That would be wonderful. I appreciate all that.
Sure. The other thing that we did that I want to talk about that we were successful with was we had developed, we got to looking and I was a little concerned we weren't in compliance with the suicide screening, the risk that needs to happen with that patient safety goal. And so they did a lot of best practices, research, literature reviews, et cetera, and they've developed some screening tools at admission, a mandatory facility-wide annual training on suicide, risk reduction, high-risk precautions, et cetera, and all of our processes. And then we actually went back, measured our compliance, it still wasn't where we want, so we've done some additional retrainings, and we seem to be on our way with that process too.
I know Anita too, you also had, it was a brief, but you had a one-day joint commission visit. And that, it's usually documentation and things, but that went pretty well.
It did. I think it was, again, a survey for cause. It was based on a complaint, and we had the same person that made multiple complaints to different organizations. And so, yes, we have some paperwork issues. We just need to do some documentation.
Right. Okay. Well, I appreciate that. I mean, it's a lot of hard work going on, and I know Dr. Adams, Gail, and Louie, all three of them, David McCullough, a lot of people are there to have been working real closely with you. Greg in a different way, as we've had to do some discipline there. Greg's a labor attorney. So Greg, that's what I used to do. It's a real, I don't know, I guess you have to have a certain personality to do discipline and terminating people.
Is that good or bad?
But Greg spends most of his time.
Consistently and fairly, you do.
Greg spends his time terminating people. So,
Yeah, well, and these are people who are in communication with each other. There's probably 4 or 5 individuals, and their attorneys are in communication with each other.
Okay.
And they're also in communication with other people out there in the community who feel like they have some interest, however narrow or self-serving it might be. But this is a change that is so obviously needed, as far as how we're doing things and how we're dealing with our kids over there. As dangerous as they might be, and as unsavory as they might appear to people who don't know any better, I mean, this is an important time in their lives to have an intervention that's really important, really life-changing. If we don't have the right environment, the right therapeutic environment, it's not going to happen. So that, to me, overrides a lot of the very narrow and self-serving concerns that we have from the union, from the attorneys, and from some employees who don't want to see this kind of change.
right. Any questions for Anita? So I know it's good. We're obviously having a lot more interaction, so that's good in terms of asking questions today. Yeah, so that's okay. Well, Mike, I haven't had a chance to come to Turquoise as much lately as I used to. I think Gail and Louie are hoping in February. They've been spread pretty thin, also. But they're hoping to spend more time in February as we start talking about as you will be today, talking about your adolescent detox project. And so I wish I had had more time to be there. I'm really excited about the project, so I want to get back in there as well. And we can talk a little bit about that today. But hopefully some of the team will be in there to support you as we get into probably certainly in February, I think, right?
Yeah.
Be able to do that.
That'll be no problem.
It'll be welcome support. If I may, Cabinet Secretary, I would like to start off with our data from the second quarter for the hospital. Again, we've been pretty busy with our adult population. We were at a 95% capacity with 163 admissions, 164 discharges. That averages out, I think, Movie Ann likes to see it with our census average of, it's about 32 patient average for that quarter out of 34 beds that we have. Again, we're usually about 33 to 34. We're a little lower than usual by 1 bed, and that's usually due to the holidays. We have a lot of folks that don't necessarily want to stick around during the Christmas holidays.
Right.
We have a few people leaving, and it's a tough time for folks to try to keep them in treatment. But we were more successful this year than I think we have been in the past, in the sense that they want to get out there and use or leave the facility. I think by us having him in there, it serves them better in the long run. So we've done a better job in that sense. I think that has to do with the programming that we've done
Right.
with our clinical staff and our nursing staff that are very involved. In the MO2 unit, we had about 890 patients that we served for the second quarter. And that was actually a little down from our average. That was about close to 300 patients per month. We're usually about 350, so it was a little bit down.
Just reminding people what MO2
Yes,
is again.
It's the medical observation treatment unit. It's our day clinic that we operate 8 to 8 p.m., 8 a.m. to 8 p.m. We staff that with a physician assistant, a nurse assistant, and we see patients that come in from the street. They're brought in by the Coast Police Unit, police officers, ambulance travel. Our ambulances are also dropping off patients, and then also the majority of our patients come in from across the hallway that's supporting the Bernalillo County MATS program, where it's a social detox model. So we're able to leverage our medical staff to support their social detox model, where they don't have medical staff on board, to make sure that those patients are safe and that they're in a safe environment, and medically they're able to sustain that 3 to 10 day social detox that they're providing for them on the county side. We did have again for the current year, we're up to about 19, almost 2,000 patients being seen to that clinic. Last year we were at about 5,000 for the year, so we're a little below the trend that we were prior year. But again, we're still seeing a lot of numbers out there. I would say that I don't see that the problem is deteriorating within the state or within Bernalillo County. It just seems that there may be some other options out there that they're utilizing, or there may be some staffing things that are going on within the county. We can't control that piece. But again, we're there to support that. Really, the focus has been for us in the last quarter is to get this adolescent program up and running. We've made successful, we've met some of the successful challenges, including the licensing piece and getting the Bernalillo County to help us out with sort of the structural changes that need to happen within the hospital. Right now, our Rita Meeks is approving a plan so that we can make some changes within the hospital. For instance, one of our big changes in there is going to be an expanded tub room so that it's available for the handicap accessibility that helps out with the entire hospital. We're expanding some of those rooms so that we would have a better capacity for the hospital in reference to handicap accessibility. And we're trying to set up doorways and some of the other structural changes that need to happen within the hospital. Again, our plate's full in reference to getting the two wings ready, from painting to stripping to getting furniture to getting the wiring, computers, staffing, the entire cabinet. So I won't bore you with the details. I think everybody here in the room has had experience with some of those the details that go along with adding a new wing or adding a new population. For us, the big challenge has been to try to partner up externally, where we include other groups, including CYFD, HSD, juvenile probation, education, PED. Those are some of our challenging, that's been one of our biggest challenges, in the sense that we have to get everybody on board with our programs so that there's a good flow of the programming. We've had a lot of success in that environment. Thanks to a lot to Michael Hawk and Daphne Hopkins, who have also helped us in sort of getting these people in the room to make sure that everybody's aware of what we're doing going forward. But again, there's some challenges along the way, and we've started identifying how we're going to roll this program out statewide. And I think what we've determined with the group is that we would like to focus on starting this pilot through Bernalillo County, potentially Valencia County, and then expanding it quarter by quarter across the state. Right. So it's a better rollout. We can get it up and running, and we can fix the hiccups along the way. So we've had some pretty good success in that. Again, we have meetings coming up. We meet usually about every other week, weekly or every other week, depending. The holidays put us a little behind schedule. But again, we're looking better and better in reference to having Albuquerque and Valencia County up and ready when the time comes to be able to get patients in the door and have a place for these patients to go once they met their 30-day stay at Turquoise Lodge. And I think that has always been our challenge is we don't want these patients to finish our program and then have nowhere to go or have,
Yeah,
something
again, we're
worse.
dealing with adolescents, you
Correct.
know, that same population we're talking about at Sequoia, that same age group.
Yes, sir.
And yeah, it's terrible. Then they go back into a really abusive environment or negative environment or something when they leave there again, which we can't completely control forever, but
Sorry, I just had
Sure.
a comment on that. And so we're also looking at, our team is charged with developing the intensive community-based services that would be the step-down accompaniment to what Michael's doing. And we've also gotten some TA, some technical assistance from one of the previous managers at CSAT, which is part of SAMHSA, the Center for Substance Abuse Treatment. Because we're looking at intensive outpatient services, but we have some frontier communities that don't have the patient volumes to sustain an intensive outpatient program. So we've asked someone from CSAT to give us some TA around what do other rural states do. And we may have to do some distance participation. There are some states in our country that are giving adolescents not iPads. That thing you have. iPad, thank you, so that they can, I don't always remember, so that they can participate remotely or looking at, do we have some kind of a traveling clinician
right.
that can go, and also retooling our JJ staff, juvenile justice staff, to be able to give the right messages to kids, and really looking at addiction as a chronic disease that there's no cure, there's no magic bullet, it's something you have to live with. And how do we arrange our community resources so that we're equipped to receive those kids back, and looking with community groups like you talked about with mentoring and all of those, what we would call non-traditional or non-clinical services that are being found to be so important in research. So we're working as hard as we can to prepare our communities. And Michael and I, Monday, are going to talk with our core service agency executive group about making sure that they're all committed to developing those receiving services in their community so that we can get this to work. So this is very, very critical, I think, for our
She
citizens.
brings up a good point in reference to, there's a 32 counties, I think it's state.
33.
33. And within that group, we're putting the ownership back within the community to receive these kids back in within their given communities. So again, we're sort of that hub where when they're done with our program, they're gonna have to go somewhere, and we're making them responsible. And I think that's where Ms. Hopkins
Right, that's
is
very
making,
important.
holding their feet to the fire so that their programs are up and ready. And it's not necessarily just a shell out there, that they really actually have programming available for these kids to go back into.
Well, one thing that, again, talking best practices, the VA is very much deploying telehealth, and on the PTSD treatment, the psychology side, it's been very effective. There was a lot of apprehension at first about trying to do telemedicine at that level, but it's proven to be very effective. And the other thing that for our younger generation folks, I've got PTSD apps on my iPad from the VA, a plethora of them that are very applicable to the younger population. If they're feeling the stress, go on your app and start talking yourself through good alternatives. So the VA is a good place to look for that.
We'd love to get some technical assistance from you guys too, because you're right, you guys have really had to, especially in a state like New Mexico, they live in remote places.
Right,
So you have to use the technology.
you bet.
So we have a grant and we asked for, what was it, Michael, 25 iPads? The federal government wasn't really that excited, so we did a counter proposal at maybe 15 to try to pilot it to see, because iPads are $300 or $400.
Right.
And you take a risk, you give it to a kid that they sell it or break it or whatever, but we're really hoping that in the majority of the cases, they will use it for the right purposes.
Right.
And it's really critical. We have to get, and I'm not a machine person, but we have to really get in that mindset as we look toward the future.
Right, we do, especially in a rural state, like you said.
So a couple other things is that, again, the educational piece, we started looking at charter schools, GED options for them. We've also tapped into the homeschooling portion for homework. And one of the things that I wanted to mention is that we've started conversations with Army recruiting, because I think that's another option out there. And, we've even looked at maybe even, utilizing, sometimes they put out, they come out and they do a rock wall, that kind of stuff, and we can do some of that stuff. So again, we don't have them for a long time, and I think there's some different challenges that Anita and Sequoia see. But again, for 30 days, I think we can start.
Right.
One of our goals is to sort of show them what's out there besides
You're
getting
trying to
behind.
give people hope, right?
And so we've started looking at the, again, we've already created a contract with Santa Fe Mountain Center so we can utilize those folks a couple of days a week. We started looking at, I just forgot the name, it's with equestrian, I believe, therapy, which is up in the East Mountains, where we're looking at the contract and they're sending us a proposal this week to see if there's options available. And some of these things, I think we're even looking not only for the adolescents, but for the hospital, because I think we sort of, our adult population is sort of the throwaway population where they've been in this situation for so long, we forget about some of the things that are available for them. So we're looking at sort of opening it up and seeing what's available for them.
And again, I hate to monopolize the conversation, but I have a meeting right after this one with Mike Keevy from Adelante, with Mr. Gardner from the Chief of Staff. And one of the things we're looking at is they're looking at the orchard up north.
Los Luceros.
No, the one that got burned out.
Dixon.
They're looking at ways that they could possibly take Dixon orchards and make it into a facility that Adelante can use for their programs. We're talking about it with veteran programs, with some of our equestrian contracts, and it could all very, very well be a statewide link-in. That numerous agencies could work with somebody like Adelante to do just those sorts of things.
Well, what would be the best way to keep sort of that information flowing from your office?
Just zip me an email, and as I go through those,
keep us
because
in the
again, we work with a lot of the same groups for the PTSD side.
Sure.
Michael, maybe we can include Sequoia in that as well.
Yeah, I definitely do. I'd like to sort of pass that information on. Again, we've set up another contract that's probably already on your desk. I think there's a white paper associated with it. Across the street, they have an Endorphin Power Company. They have a rock wall. They have room for us to have meetings. They have a garden that you can utilize. Some of those things, we're looking for that for our adult population as well. So those are some exciting, we're trying to look for low-cost options out there so that we're not costing the state a ton of money, but again, getting these folks, getting them out in the community or seeing things that are options out there besides, some kind of TV.
Right, so they don't just keep coming back.
Exactly. Again, the staffing is one of our issues that we need to get the staffing posted so that we can hire on that. That we had talked about a timeline on when we were going to get this program up and running. I had floated out the number back in about starting up in February. That was our goal, and I think internally it was a good date to put out there because it forced everybody to sort of get things done internally. And we've done that. Unfortunately, staffing takes a little bit longer and getting those through, and I think that's pushed our date back.
So you got to go through quite a lot of approvals.
Yes, sir. And then it sort of ends at the end of the day. It ends up on your desk because it's executive.
I think as we also go through the LFC process and everything now with the budget and all that, but it's going to be fine.
So I think from that perspective, we're shooting for 2.5 months once the positions are posted, so that we can get the folks to advertise, interview them, give their old jobs their 2-week notice, get them trained a little bit, get them up and running, so that we can start this project, this pilot project, even if it's not with 20 beds filled on the first month.
Yeah.
We can move up to that number.
Right, you want to graduate up to that.
Yeah. Again, we have to include some changes to our food contract, which we've already worked on, because again, they take one of the benefits from this program that we see internally, and I think the county is on board with it, is that right now our food contract, we can always improve cafeteria food. I don't think anybody has ever said that that's the 5-star capacity there. But I think one of the things we've looked at is because adolescents are being looked at, is that they have a higher nutritional and calorie count that they have to bring into place. So I think it's going to improve our food. And since the kitchen's going to cook one meal, I think all the patients are going to benefit from that, including Max. So we're looking forward to that experiential, again, going out into the community. And then the only other thing is we've talked about the vans. We need some ability to get these folks out.
Right. Yeah, we'll talk about that again on Friday too. you know, so you know, I know you need to get at least one.
Yes, sir, and I think that'll
Starting
get us
out.
through. And then and then training, internally, we're looking at some CRA training, it's a model that's out there that's SAMHSA approved. I think we're looking at rolling that out for not only our ACRA for the adolescent program, but also for adult program. And we have, you know, there's just a lot going on in there. And,
Yeah, we want to spend more time down there, so that's where you guys will be gravitating to.
Well, yeah, we're looking at probably the first or second week of February, just to come visit with you for 3 or
By
4
then, we
days.
should be, it should be nice, you know, the facility should be up and ready. The only thing we're gonna need is staffing patients to get in the door. And then I think
Sadly, you won't have any trouble finding patients.
yes, I think we'll have a list out the door. One other thing that I would like to mention before I stand for questions is that we did get through in the interim through this, since we didn't have enough to do, is we created an IB contract with UNM.
Right.
And that, an IB therapy contract. They're gonna supply us with some patients. They're gonna pay us to take those patients in up to about 5 weeks. The contract, it stands to make the Department of Health close between $250,000 and $500,000 to supplement some of our changes in our revenue stream. Again, I think that's sitting somewhere on administrative desk, so anything that we can do to get that pushed through
Yeah, I'm
sooner
not
than
sure where
later
that is.
will get us, I think we mentioned something to Kathy, we could track that down, but I know that it's up there in the Santa Fe offices. We could get that signed off on, Mr. Graff, I think that would help us in
Okay.
getting that up and running. And I'd like to do that prior to getting the adolescents up and running so that we can work out the kinks on that
Okay.
prior to that. So,
Like Kathy,
exciting news there.
know where that's
It's still an ASD.
Okay, all right.
ASD.
I don't have a question, I have a comment, particularly to Mr. McGrath.
Sure.
This initiative is very important to CYFD, it's very important to Secretary Dynas, she and I talked about it. And I really want to thank you for your personal commitment, because without that, I don't know that we would have sustained the program through the LFC questions and that kind of thing. I just really want to recognize you for your commitment to
Great.
this. This is critical.
I think LFC is also very supportive of this adolescent project. So money's tight, of course, you know, but you know, I think we have their support also.
Well, we're working on, you know, again, I like to focus on budget to begin with, and I think we're not going extravagant on this. We're trying to bring in the program at the lowest cost to the state and finding out if, the other thing that we're looking at is finding out if there's ways to support this through Medicaid dollars
Sure.
down the road. So
I know
again, we're looking
there's
at-
not a lot of reimbursement, so that the IV monies will be very helpful.
So again, we're looking through all that.
Okay.
And I think the only other thing I had was our flu vaccinations for the staff. We're at about 67%, a real good percentage in our part of the world. For some reason, there's some staff that feel that it makes them sick or they don't need it or whatever the case may be. And we've sort of tried to educate them that by them getting sick, they could end up getting
Everybody
one
else
of our
sick, too.
patients sick, and then they're at higher
We're
risk.
definitely in flu season nationwide right now.
And the patients, we offer that, the flu vaccination to all our patients, including the MO2 patients that walk in the door. We're about 65%, we're about close to the same percentage with patients that accept the flu
Good.
vaccination. So
It's great.
we're trying to do our part in reference to trying to keep that from spreading out. So at this time, that's my report, and I'd stand for questions.
Any other questions for?
One thing I'll add, I met Dr. Laura Allen.
Yes,
I
I
just started there. I am just really tremendously impressed. This is a young, enthusiastic, young doctor, which I think will be a real big addition to Turquoise.
She's actually worked with us part-time. She's had to sort of take on a bigger role because Dr. Kamorme has taken on a lesser role. So again, I like to mention that Dr. Allen doesn't like to sleep very much, so we have her day and night, and she loves that. She loves the environment. She's really committed to our patient population. So we're very fortunate to have her, and I'm glad you had the opportunity to meet her. And hopefully she'll meet some of the rest of the staff when you get a chance to tour.
Okay, great.
Michael, those dates will be February 6th, 7th, and 8th.
February 6th, 7th?
And Gail and I and Dr. Adams perhaps will join us a couple of days and just meet with you and your staff and see what we could do.
Right, perfect.
If Katrina's available then too, that'd be good too.
I'll make sure I do that.
Perfect.
Okay. I know it's taking a little bit longer, but it's a very good conversation.
Sorry
I
to.
know, no, that's okay. As we're going through it, I know Secretary Ward will be, don't take it personal. She has to leave at 11:30, but it won't be because you guys said anything that offended her, I hope, you know. So John, with all these programs are complex, but we'll ask you some questions as you're going through your report too for Los Lunas Community Program.
Thank you, Brad. First item, just regarding census with Los Lunas. Last quarter, we were up a couple of individuals. We're basically at admits of crisis and emergency situations around the state. Other than that, we are at capacity at present time. So that takes us up to an unduplicated count of 82 at present time with Los Lunas. One of the major items the last quarter has been Los Lunas' involvement with the DOH quality management team with Gail and Louie, basically covering a variety of areas related to improvement for Los Lunas. The heaviest emphasis has been on the healthcare area, the IT or information technology area, doing some trainings and development of some committee structures that leads us more into root cause analysis of issues, situations that arise as you run an agency or programs of this type, but also and the restructuring of performance improvement department performance improvement plan. So we have had a very direct connection the last quarter with Gail and Louie and Dr. Adams' group, and we're starting to see the benefits of that as we continue with it. We're happy to have that support. It's helped immensely. We also received a visit, and we haven't had Jackson compliance officers with the ongoing litigation physically on site for probably about 6 or 8 months, but we did receive a visit from Lynn Rucker, who had spent the day with us and with our consumers and in our facilities. I don't know if it's occurred in the past, but we actually, the verbal exit report was very positive. We always are wondering if the follow-up will be as positive. This was a case that it actually was, and then we do have formally on record of positive impact with Los Lunas.
I was with Lynn Rucker, with Judge Molson and several other officials, involved with Jackson, and she was complimentary of Los Lunas in that meeting, and they had a lot of compliments about Ida and Jill. Marshall?
Yes. I think our management team that's been developed within Los Lunas, as we were able to fill some holes, Jill Marshall as program director for us has been very positive. Also, Ida formerly has come on as DON. She was an existing staff member, but really minimal time with us, a couple of months prior to that. That kind of fills our holes within that management team, and we feel pretty confident going forward with that grouping. We continue to meet with DDSD, Developmental Disability Support Division. We contract our Medicaid programs through. We meet with them monthly. That's been initiated ongoing, just so they know that we have a direct connection with them in terms of what's occurring at Los Lunas and also what's going on their side of things, especially with the implementation of the Medicaid waiver with that renewal and pretty significant changes in that. I would like to offer to DDSD that Los Lunas as a site to really be able to gauge financial impact or services impact with that new waiver, that I think there can be a pretty good information flow from us over to DDSD to be able to provide them information on the way the waiver is working out, and that pushes out to a statewide basis. But we would like to offer that to that division. We, Los Lunas, all residential facilities are leased. So we presently run with about 25 residential settings that are leased. We are basically at capacity. We are taking a look at our lease structures and any options we have related to that. Although we are in our most intensive health intensity need home, trying to keep one bed basically open for a new program coming through the waiver that would allow for some emergency medical need placement in our facility on a short-term basis, usually from family situations rather than from, say, one facility to another. This is to impact the family unit that's having difficulty.
And I think, John, on that one lease you've been talking to Jim Green about, I guess you just keep talking to him about that one issue.
That one lease issue, I think we have agreed upon direction to
6 months.
Be heading on that. We will be setting up with that parties involved to physically meet, do a walkthrough there. But I do envision a exit at some point.
Yeah, I just think just so you're in sync with Jim on that about what you want to offer, I guess.
Right. And in general, that 6-month situation is where we're at with that one. But we did have 2 new leases that we initiated, really replacement from one home setting to
I think
another.
I signed those. I think I did. I think I signed
you did,
those.
because we're moving. So I think they were
Pretty bad.
Hopefully.
yeah,
That's not real decisive.
I may have a surprise back at your office that I'm not aware of, but at present, I'm assuming.
Should sound more decisive. I signed those leases. I did.
We also, risk management, we had, I believe it's a Travelers Group insurance carrier related to risk management on the old Los Lunas campus facility. We had, again, an audit conducted there. We had about a half dozen items that we're responding to in terms of what was identified as things that need to be addressed. Things that need to be addressed also usually include financial impact there. We've gotten the bids related to that up to Michael Brown's office and also to property control at present, and are awaiting word on how to proceed with that. Thing we do watch out for there is we also, on that campus, is a corrections program that they house individuals there, that we want to make sure that does not cause them any bumps in service delivery or anything of that type. So we're working with it. In terms of biggest change programmatically for us is as we work our way through things, healthcare was the high profile priority item for the past quarter, but now we're also starting to take a look at the type of day programs that are being offered presently through the Los Lunas program. What we're trying to do is push as hard as we can for a formalized community integration approach to what our consumers are receiving there. And that is in the works. We basically have made some major changes there that are being implemented basically as I speak, and we run through with it. The personnel-wise, probably our biggest spot that was filled was that director of nursing position. I think, as with other facilities, try to ensure that healthcare area is operated as it should be. And then we're feeling much more confident there than 6 months ago when I would bring up healthcare. Also, on the flip side of that is our ability, with the changes we've made, to attract additional nursing staff. What we're starting to find is some of those changes have made a positive impact there in terms of our ability to start to look at filling some of those nursing vacancies.
Sure.
So that's much better for us also. The one issue I think when we, as it is brought up related to wage issues and such for staff, we always know that's an issue, is, and will continue to be. But we have made a very formal push from administration on down to formalize, for lack of a more therapeutic term for staff or whatever. It is just basically a staff morale committee that we're meeting every other week now to try to develop some areas and potential incentives for our staff. Those have included whether it's the ice cream socials, whether it's the barbecues for staff, is just appreciation dinner type of things.
No, they're real important. We've been doing that up in the Reynolds building. We had a big, huge, 350, 400 people, I think, at the Halloween one, and then again at the Christmas one. And so they're big issues. I mean, it's important to people to do that.
I think we've taken two approaches. One is overall for staff, but also to try to individualize it. We have a lot of smaller departments and such that operate that you don't see as much of, and it can be as simple as breakfast burritos for that graveyard staff out in the homes, those type of things. We are limited.
Or they feel forgotten.
Financially what we can do, but also, so we're looking at those things. We've started to do some fundraising activity through that committee. So that's been good. So hopefully we can continue to make that push. We are, last item that we did have our ICF, our intermediate care facility, basically had that annual survey that is for individuals with criminal history related to sexual issues for the DD population. We had that review. We had no major findings related to health and safety. We did have, we will be doing a plan of correction on some facility issues. Have not received that report at this point in time, but I would consider from their verbal report on exit, things that need to be done, but they're fairly minor in nature there.
And you keep working closely with Gail and Louis. I know a lot of those things too, right?
Yeah. That is, again, we're waiting on that report. We're
Sure.
also waiting for the rollout of the DD waiver itself to see exactly how that will impact. Programmatically, it'll mean some changes, but I think positive changes is my feeling really overall in terms of the service delivery that DDSD was looking for
Right.
with the new waiver. So other than just that kind of unknown, waiting for dates and making sure how this will roll out, we're fine. So all is well. I'm feeling at Los Lunas and feel like we have a staff there that
It
I'm
looks like
very
maybe-
happy to
It
represent.
sounds like you'll be having a hospital in your neighborhood in the future.
Yeah.
Loveless is talking about building a hospital
Yeah.
down there, which is good. You know, when you have to take
Positive
people
for
to
us.
the hospital, you have a long drive right now, right?
Correct.
So someday in the future, there'll be a hospital there. I guess it's Loveless Sandoval or something it would be called, whatever it's going to be called.
That would be
Valencia, I'm
major
sorry,
impact,
Valencia,
yes.
I mean. Yeah,
Valencia.
Loveless Valencia.
that hopefully rolls right along and get something there, right? So I stand for questions.
John, I'd like to make a comment. Yesterday I spent some time with a QMB group in Las Cruces, and this is the second time they have commented on how well John and his leadership team has improved the care with your consumers. So I just want to publicly congratulate you 2 times in a month. So I think that's pretty remarkable from QMB.
I'll relay that to our staff,
Do.
and I represent them and
And,
I'm proud of them.
Right,
I agree.
right.
Thank you.
Okay.
You bet.
And well, I'm very, very happy to have Lori at the table with us again. And Lori does a fantastic job there, and having Donna go back and join you, you're gonna have your team together again.
I can't wait.
So, we'll ask you some questions too, we'll let you go
Okay.
through your report.
You bet. As you can see from the report, the census is staying right around 122. It remains that as of today also, as it was at the end of the year. People coming in, people going out, so it stays fluid right about 122. I need to, we're reviewing those applications for admission on a weekly basis because I need to get our census up to around 130. I have to remain at a 90% occupancy in order to continue to receive the VA per diem for those individuals that go out on pass. So as it stands right now, if someone goes to the hospital or wherever, if they go home for a while, we don't collect the VA per diem for those days. So they only pay that if you're at 90% occupancy. So that's the goal for the facilities, to remain right around that occupancy.
How long does it take to be, as you're carefully screening those?
Yes.
When do you think you would possibly get to 130?
Probably the middle of February. What we're trying to do is to do at least one admission a week. I usually try to do one at the beginning of the week, and then possibly, if we can, depending on what's going on in the facility, maybe one later in that week. So trying to turn 1 to 2 a week, so it's going to vary, but I'm hopeful around the middle of February.
That's great.
Under the projects and construction, as everyone is aware, we have a grant application in with the VA for the new Alzheimer's building there on the grounds. That is in a bureaucratic red tape quagmire at the VA. The priority list is supposed to come out in August of each year. Unfortunately, it has not come out yet for last year. The VA, because of the fiscal cliff, has not received all of their funding either, so they haven't wanted to finalize their construction and grants priority list. So they're right on the fence, or they're saying, yes, we're probably going to do this, but we don't know when. So I'm hopeful that we'll be on a conditional list for approval for that grant in March. So what that means is once we get on the conditional list, all of our documentation and stuff is in line. So if someone else that has had a project that they've been working on for a couple of years does not have the funding, then we move up and then we would get our funding right away. So it's one of those things. Today you may be on the conditional list, tomorrow you may have to start construction. So we just play that very, very closely every week, every month that we deal with them.
Just telling everybody again that with that project, to just tell everybody the whole scope of that project. I know you mentioned Alzheimer's, but what you're envisioning there.
Yes, the way the plans are worked out is there are 39 Alzheimer's beds, and then there are 20 skilled beds. And the way the VA has transitioned, they're into small home models. So each one of the homes will be 13 beds for the Alzheimer's and 10 beds on each one of the homes for the skilled. We do not have any of the central functions in the new buildings. They remain in the old building, dietary, for instance, those types of things. There are some offices in the new building, but it allows us to care for those individuals in a new environment. Everything has private rooms. Everything has private baths. That's the way the VA is going, and we're wholeheartedly in support of that, those ideas. So that's the way the homes will be structured. It would be located, if you're familiar with the campus, right there on one of the vistas on the actual grounds of the facility. So it's in close proximity to the old building, but the new building isn't in competition with the new building construction-wise. So it's a seamless, it looks like those buildings would have been there for quite some time. So we're very excited about getting the ground broken on that new building.
Lori, how would,
Yes.
maybe I should let you finish, but
That's okay.
your consideration for staffing with that new model
Yes.
of home
Mm-hmm.
is going to be quite different than the hospital setting.
Yes,
And
it is.
so I'm sure you're looking at considerations for staffing with that model.
We are. We will be putting a presentation together for a presentation to DOH as well as the union for what they call the universal worker.
Okay, good.
So that those individuals that would be housed with those individuals on their shifts would be able to do the housekeeping, the dietary,
that's
as well as
fantastic.
the CNA.
That's fantastic.
Yeah.
That's a big trend.
It
in
is.
facilities now.
There is not a universal worker right now in the state
That's a
mix.
new term, isn't it?
It is, and so I think there's opportunity for us to negotiate with both the union as well as SO to get something classified that would encompass that worker.
That's really exciting.
As we once I know that for sure we're going to get that grant and we can get going, then I'll be making that presentation.
Could you let me know how that progresses?
Oh, absolutely.
Well, I'll be visiting with you,
Absolutely. Oh, yes.
but that's exciting to get that job classification.
Yeah, there's already best practice models out there in the United States with the state veterans homes, so I'll be able to rob some information from them so we can show how that's working.
Thank you.
It's kind of a full circle, ironically. I know in hospitals, we used to talk about, I wasn't there probably in the old days, but everybody used to talk about the old days when the nurses had the caps and
Yes.
the white outfits. They did everything. They were
Right.
universal workers.
Right.
They didn't have housekeepers and CNAs and all these other people. They did everything. So they were a universal worker in the old days. And so you always hear those stories about the good old days, you know.
Absolutely.
And there's a trend now in reinstituting the universal employee in healthcare.
Correct.
Yeah, are you gonna need additional staff, or do you have the staffing you have now is enough to make that work?
I think in the phase one, ours is a 2-phase project also. The second phase is assisted living. I think in phase one, we'll be able to access the staff that we currently have in the building. There may be some additional, maybe some CNA or the universal worker type staff members that may be needed. But as I envision it now, there won't be any new staff that will have to go over to the new building. So we'll utilize the individuals because we'll close down one of the units in the existing building that we currently have for our Alzheimer's. They will go over. We will just have to split it up between the 3 houses on how that works.
We're gonna start looking at other facilities for positions.
Well, I'll be looking to you.
It's all more programmed.
That's right. So
We know you have a bunch to spare. So.
that's right. Some of the other projects that we're working on, I listed them all out there, but I'll just kind of briefly go over some of the things that we're doing. On the MDSQI, those CASPER reports that come out on a monthly basis, we're reviewing, my team and I are reviewing those on a weekly basis. We get the new ones the first of the month, of course, and then we're looking at what exactly is contributing to the numbers that come on those QI reports. And what I am finding is that it is a matter of inappropriate charting. We have the Care Tracker program wherein the CNAs and the nurses enter data in the Care Tracker. However, I don't think that the staff have had enough training to understand exactly what they put into that Care Tracker and how that drives those MDS numbers. Because I'm looking at those numbers and the individuals that are flagging, they don't make sense.
Yeah.
So we're in the process of sending 2 individuals to that Care Tracker training.
Right.
And I think it's vital. So they'll come back and then we'll do the train the trainer program on that. So that everybody understands exactly when you punch that button, what does that mean for that resident?
Well, and the fact that your staff, it's very common in not just your staff, but with healthcare staff, don't take credit for what they do.
That's correct.
And don't enter the answers for the questions they've asked the patient regarding pain or nutrition or any of that. And so they don't get credit for that. So it's not registered anywhere. So the documentation doesn't exist that they did screen for pain.
And we have some individuals that are, I'm down some social workers and we're actively recruiting on that. But so I have a nurse that's maybe is taking up our Alzheimer's population for that, who really doesn't know them that well. And so puts in answers that may feel are correct, but I know looking at the report, there's no way they can be correct. So it's a training issue. So I'm actively looking for a formal MDS training to send them to so that they can come back and then when they do those, they understand how things are driven.
If you find, I know I tried to support you, but if you find a good training for MDS, please let me know.
I will.
I know there's some that universities have and so forth, but if you have, I'll continue to look for you too, but it's something that DOH should look at.
Well, and I'm going to reach out, I've been reaching out to the other state veterans home across the United States. I'm fortunate to be able to access every single one of the administrators. So I can send information to them, and I have been reaching out to them regarding falls, pain, restraints, different best practices that they have instituted in other state veterans homes So I'm getting information in piecemeal. Of course, I did that right before the holidays, which was a mistake because everybody was gone. But now that people are starting to come back, I'm getting answers to the emails. And so I'm getting information about those best practices so that I can share with the group. And that takes us into the same thing with the restraints reduction and the falls reduction that we're looking at the facility.
Yeah, this is the day-to-day stuff,
Yes.
but it's really important. And
It is vital.
that's our, kind of our sacred duty to the patients that we have, that we constantly be looking for ways to make it safer.
Absolutely, absolutely. There's, it's interesting, if we talk about the falls reduction, the information that I'm getting from a lot of the other state veterans homes, a lot of the things we already have implemented. So I'm looking for that new and improved thing that's out there that somebody can tell me that I haven't tried already that may or may not working. So there's a couple things that have been coming up that we'll be looking at implementing. I'm hoping that maybe we'll see if there's some changes on that.
Great.
So same way with the survey readiness plan. I've instituted the departmental rounds once again at the facility. We did that several years ago with the department heads. And I have a structured calendar that is set up. I received some best practice materials from the Veterans Home as well as on the internet regarding the survey readiness, the mock surveys, the actual survey tools. I have a binder of different tools that are available to each one of the department heads in their areas. There's a whole bunch on nursing, there's a whole bunch on dietary, those key areas. And so what we did is we took one of those tools, it's a 3-page document that focuses on different areas as the person is going around and surveying. So we started that on Monday of this week.
Great.
So those are being done by the department heads. They return that document to me at the end of the day. Then we review it at the next stand-up meeting the next day to say, okay, hey, this is what so-and-so found, and then I make the referrals to the department heads. Housekeepers, why don't you check on this area? Nursing, why don't you check on this area? So we're going to try that for a month on this one particular tool. We've already found some redundancies that we'll be able to streamline the tool with a little bit better. And so after the month, we're going to review that and then see if we need to implement the same thing, if we want to change it, however we want to tweak it. I have found that if I structure the department head's time on the date that they need to do their survey, they do much better.
Oh, okay.
I am letting them pick the time. And several years ago, I put the time that they had to go and do the survey and do the inspections and stuff. Now they get to pick their own time, but they have to do it twice in that day that they're assigned.
I get better quality.
Exactly. So, but I have every single unit, including dietary and the dining room, as special areas that they have to look at, as well as the entrances, the lobbies, those types of things.
That might be applicable to our other facilities as well.
So yeah, let me play with it a little bit and see if it works and see how the department heads want to streamline it, or if they feel that it needs to be, then I'll be happy to share it with anybody else that wants it.
Perfect.
One of the other things on the volunteer program, we are planning a grand reopening of the recreation building on January 18th. We've been working on that project for a while now. We have several individuals in the community that are very, very anxious of coming in and volunteering in the facility. We started this back in February of last year. And so we'll be re-inviting them to the facility. We're going to have a big party to show off the new recreation building that we've had remodeled. Everything we do along those lines are done with donations from the groups that come into the facility, those veterans organizations that support us. I want to formally thank every one of those individual groups that came in over the holidays. They start asking in September, October of what the wishes are for the residents. And so the residents put their Christmas list together, and we send it out to each one of these groups, and the groups come in and provide every single item that is on that resident's wish list. It does not matter what it is. If a resident wants a TV, if a resident just wants magazines, whatever that individual wants, those groups come together and they put those gifts together for the groups, for the individual residents.
That's great.
And over the holidays, we normally have, usually every weekend, there is a different veterans group that's in there, the American Legion Riders, the VFW, the American Legion, and they have come through and they visit with every single resident and they give every single resident a gift. It's very, very heartwarming to see that, and I'm very appreciative of those groups that are across the state. HR, we continue to do the local newspaper advertisements. I sent letters to all the registered nurses in the state of New Mexico, starting with the group in the southern part of the state. I did have 5 immediate hits from that letter that we referred up to HR, and so we're working on those things. Of course, we're waiting for the reclasses to come through because a lot of our LPNs were reclassed to RNs, so we're waiting for that to come through so that I can
I think we're very
utilize
close
that.
on that.
And so we're doing that. We do have a job fair that's going to be probably in the next couple months. That's with Western New Mexico. They have a campus office there in Tier C. So we're working with them on a job fair. And I hired a couple people this last quarter. Not as many as I would have liked, but we're working on that. And I think that's the highlights of my report. Just
Yeah, and
a
you
little
had
bit
the,
about
I
the
guess, the
infection control.
rotavirus and the norovirus.
Basically the same.
Basically the
Mhm.
kind of same. You feel the same.
They do.
Lousy.
Absolutely.
I want to
Miss
echo Brad's remarks about the beautiful campus and the facility at TRC. If you've never seen it, it is absolutely beautiful. And those employees have so much pride in the way they keep that place up. It's just incredible. The courtyard, the waterfall, the drive-in, the way you drive in through the facility, the roundabouts, everything, the curbs, the lawns, the trees, everything is just so beautiful. And they do a fantastic job in keeping that place clean and all the turtles running around in the courtyard.
They're a little slower right now. They're hibernating right now. So running around.
But they do a
It is
fantastic
beautiful.
job down there.
One of the few places in TRC with green grass.
It
Oh,
is,
yeah.
Yes.
Yeah.
Yeah.
I'm just taking it from the Rio Grande before it gets down to Might as well. I just take it before it gets down south. So. I know.
Again, the importance of that facility in Fort Baird, the signature injury, and one of the things that we're looking at from a strategic viewpoint, the signature injury for the current war is TBI. And everything's pointing towards increased incidence of Alzheimer's. So we're trying to take a look at the number of Alzheimer's beds between us and the VA system we're going to need in the next 10 to 20 years, because that's when the most severe TBIs will start to show the indicators of Alzheimer's. So we're very, very much concerned about getting this wing built. If you drive by the VA hospital here, there's a 7th floor being put on. A large part of that is another Alzheimer's unit.
Wow.
So we're all looking at that from the aspect of what are we going to need in 10 or 15 years that we have to prepare for right now. So the unit here and what we have down at Fort Baird are very, very important to the veteran community. So
Yes.
thank you for what you're doing.
Thank you. When we put that grant application together and I did my research in New Mexico alone, over the next 25 years, they're predicting at least another additional 400 beds just for Alzheimer's. Right. And that has nothing to do with long-term care.
Right.
And that's what we've tried to express to the Military and Veteran Affairs Committee. Those are the capital projects we're starting to try and push across the state.
Everybody's looking at the hospitals too, with both population growth and then the aging
Correct.
population.
Are you looking at a different age group of 40-year-old
Yes.
opposed to being in with an 80-year-old?
Yes.
That is what it's,
And I think
Right
that's what spurred the VA to adopt the individual house model as well as the private rooms.
Right.
When you have your interactions with individuals in a facility, it usually comes from a roommate doing something to another roommate that they shouldn't have. And so if you have a private room where people can, have their stuff,
Right.
yeah.
And a private bathroom.
And a
So
private
lot of
bathroom.
those battles occur around.
Absolutely, absolutely. So we're very happy to go with the
Yeah, a lot
individualized
of
model.
money and capital challenges
Right.
going forward.
They really are. And we're also looking at, I've been talking with the Veterans Military Affairs Committee is also concerned that right now we only have 2 state facilities and really only 3 facilities in the VA system, mostly concentrated in the center part of the state, and except for Fort Baird, which is a very small
Right.
facility.
only 40 beds.
So we're looking, at options across the state.
Right.
So,
Well, and it seems that several of those veterans will be still fairly young
Mhm.
as their because I didn't really realize there was a
Right.
connection between TBI and Alzheimer's, but some of them, if
The,
they're in their
what's,
20s or 30s, they're gonna.
what's really key to it is the NFL data that's coming out. You know,
Yeah.
the number of NFL cases are now being correlated to what's happening with our veterans.
How scary.
It is.
Yes, and we call it Alzheimer's, but it's really any type of dementia that
Right.
could be sustained by any of the.
Right, so it's not an
It's
old
not
person
just,
thing.
that's exactly right, yeah.
Right.
It could be dementias.
Brett, just to put it on your radar, once we get our 180-bed nursing home facility done, we still have the Ponderosas. It's a 2-story building, 91 or 92 beds there that could be licensed.
Oh, that's true.
I mean, I'm just thinking of revenue.
Yeah,
That
that
is something we need to put on the radar.
yeah, that's valuable. So
Right.
And we're looking at, what, 4 years down the road, probably,
Yes.
3, 4?
Right.
that would be available though.
You have the
So
infrastructure.
that would be good. You have the
I could get
infrastructure
this
there,
out,
where
we
you
could-
qualify for the VA per diem and pay for itself.
Yeah, that's a good thing to keep in mind.
and there is lack of resources up north,
Right.
in northern New Mexico.
Yeah, that's what's hard. A lot of the veterans in northern New Mexico, they want to stay close to home, so they end up going to Colorado.
Right.
They go into Walsenburg and whatnot,
That's good to know.
instead of going much farther down south.
How many beds was that again?
It's like 92, I think, 91, 92, somewhere in that ballpark.
That's very good.
Okay, yeah, that's good for Secretary Heller to know that. Okay. Let me go to Roswell, Janie. And, you know, I still have family in Roswell. I never actually see you that often, but
It's in passing.
or them, I guess. But so why don't you go ahead and I know you're excited about the PTs. We'll talk about that somewhere in your report too.
Right. For the rehab center, you can see the census, our quarter average was 6 on medical rehab and 14.5 on CDU. For the medical rehab unit, census sort of drops in the winter time, and then with the holidays, it stays low. On CDU, we lost quite a few at the Christmas holiday. They went AMA because they just don't want to be in there during the holidays. On construction, our building is complete. We have a few issues that are outstanding, and instead of working directly with James Construction on those, we're going through the warranty department to get those minor issues resolved, and we hope that's done by the end of February. For recruiting, we actually, for the quarter, hired 9 new hires, 2 LPNs, a social worker, a nurse tech, 2 therapy tech, and 3 maintenance workers. We did 3 promotions within the center. Our occupational therapist went to our director of rehab, which opens up the therapy position now. We took a nurse to our infection control position, and then we promoted one of our boiler operators to our support services. Our hires in January, which are, what we're counting on to be able to increase census. We have 2 PTs that we hired that were at the hospital in Carlsbad. And one of them actually started Monday, the other one we're pending the rest of the signatures to get him in the door. But those are big, big hires for us.
Right.
We've run the last
I'm not going to be
several.
able to go in there anymore. That's my old hospital in Carlsbad. I'm not going to go there anymore after we took the 2 PTs, right? They won't invite me in.
Yeah, we had been running the last couple of years with contract therapists, and it's expensive. So these 2 coming in will allow us to take census on our medical rehab unit up to about 12, which is the first time in several years that we've got to run that kind of capacity on that unit. We also have hired a new CDU counselor. She actually started today, which will give me 4 counselors, which will increase census on on chemical dependency to about 24. And we've taken a director of nursing from Fort Baird. Sorry, she starts the 22nd.
It's okay, Jane.
Which we need because we've got a lot of new staff that in the clinical area, especially nursing and the techs. And I'm hoping with the director of nursing, we can get some training going so we can actually increase census. So on our medical rehab unit, we, try to do some outpatients along with our inpatients, and we haven't had the ability to do that much with the shortage of therapists. Now that we have the therapists, we found out that in December, Medicare, CMS changed the regulations. So we are capped, we fall under the cap for outpatient services like a nursing home does and home health care agencies. So we're capped at $3,700 between all three therapies. So that has, per patient, per year.
You could get more, but it's a process of trying to get all.
It's got to be, it's a manual review of the process, and it's got to be pre-approved. And if it's found not to be medically necessary, then they're responsible for those charges. So we're going to focus more on increasing census inpatient because that's what we're there for. And maybe run a few outpatients, but not as many as we had originally anticipated. On CDU, like I said, with our new counselor, we're going to increase census there. We're working with Healing Garden, and I met with them yesterday, and we're going to bring them down, and we're going to start focusing on policy and procedures and a new admission process for the CDU to sort of streamline that so we can get census up on it.
Right, I saw that, that's good. I talked with him also.
Yeah, they will be down every Monday. We'll be meeting every Monday from 2 to 4 to work on policies and procedures for that unit.
Okay.
Are they still using, did they take to the screening tool that we revised, that I revised, or did they go back to the old one for the CDU?
The actual tool itself, we still use the same one. The process is sort of divided right now because they're not in the building, 24 hours a day when the admissions come in.
Right. Wow.
Congratulations on the PTs.
Yes.
Yeah, that's huge. There's just not enough of them anywhere.
No.
I'm not sure how we did that, but I'm glad we did that.
Our contract PT is good friends with them.
Right.
And he talked them into coming and applying, so.
Fantastic.
Yeah, I helped out at Carlsbad for a while. Any questions for Janie? Okay. And then going back to Donna. So again, first of all, I just want to say, Donna, I know it's easy for me to joke about that, but you were sent over there a long time ago as a temporary.
Yes.
Which is a terrible word, right? That was almost, 2 years ago or something, or a
Yes.
year and a half, 2 years ago, you were sent over there on a temporary basis.
For a few weeks.
A few weeks, and you're still there. So fortunately now, as you'll talk about in a minute with the new administrator coming on board, you'll be able to go back and team up with Lori again. So I do appreciate all the tremendous work you've done over there over this long period of time, and all the travel, especially traveling back and forth, especially in winter time.
That was
really
fun.
hard on you.
Well, a big part of that also was when we were still trying to get out from under the DOJ lawsuit that had been going on. So.
Right, you've just been great with all that. So you you can feel good. I think you can look in your rearview mirror and feel like you accomplished a lot, right?
Good staff over there. When I went over there, there was good management over there, and they had things in place because of the DOJ. And because of those reasons, they were hyper vigilant. We're through all of that. We got through the VA surveys with 0% deficiencies. That first year we had to go back in. So I'm very proud of that and proud of the staff. They have a bad reputation in the state. They had in the past. But I think we've got a good reputation now and a good waiting list for people to come in. So they still want to go to Fort Bear. So I'm proud of that. And I want to thank Brad. From the time I met him, he understood I wanted to go back to Tier C. That's where my home is, family. And he got a reclassification for the administrator's position because basically we weren't going to attract anybody with the position we had at that time. So just recently when it got reclassified, got that new person in there quickly, and I'm very appreciative. Brad, thank you very much.
Sure.
And your team.
Sure.
for my report today. At the end of December for the quarter, we had 122 census. We have 125 today. Of those, of our 40 beds, we have 29 are veterans, and that's always a good population that always wants to come in. CDU was a little low, the holidays again, so we only had 5 and no veterans in there. So if you look at the marketing system here, just take a look, but really we market through all of these organizations in town, and we are very privileged to have that communication with the community. They come in, they help out. Our marketing person, Adrian, is involved with these organizations. The VA especially is just constantly coming in there during the holidays, like the Veterans Home. They are our main group of organizations that come into the facility and take care of that group, and very much appreciate.
Donna, too, on that, too.
Yes.
I'm interrupted a bit, too. I think, again, when I've got Gail and Louis, Dr. Adams stretched so thin, but when they do have the opportunity to spend some time with you, we are looking at exploring the possibility with you or your successor of raising the cap there, I think, on the 125.
Yes, that would
right?
be very helpful. I think Louis and Gail were talking about pretty soon coming to Fort Bear. Next week will be perfect, yes. Then you can look at the nursing situation while you're there too.
The key to that, that's what it all comes down to with the DOJ history there. We just got to make sure we have safe staffing without running an excessive amount of overtime. That was always Secretary Torres' concern about raising the cap, was making sure that it didn't stretch our staffing so thin that they had to work double shifts and excessive amounts of extra hours to cover, even if it's 5 more patients. But
we have gotten the OT down pretty good, so I'm proud of that too. Yes,
What's
George.
your cap now, Tom?
Our cap is 126. We would like to eventually get up to 150, but not today, you know.
right.
Even with 200 beds, that is what I feel that Fort Bear.
Well, I want to work
Can
with
do
you.
eventually.
I want to work with you on that too, and that's
Sure.
just, I think this will be the best way to do that.
Yeah.
You know, just keep
Increments
working your
up.
way up.
Yes, thank you.
I'm supportive of
As
that.
soon as we get those reclassifications, get some more nurses in there, I think we'll be set.
Okay.
Very good. I'm also proud that we have good communication with Gila Regional Medical Center now. We have had some problems, but we're working with them. I think all of that issue is about gone, and we meet quarterly with them now, and that's helping out. Updates? Hey, the administrator position has been filled at Fort Bear Medical Center. Yay! And the interim administrator is going back to the Veterans Home as the assistant administrator. Yay! Our last job fair was held on November 28th, and it was well attended. I will say that I've had a couple of people last week come in my office and tell me goodbye. Yes, and the reasons are my CNAs are leaving, they get better pay at the local hospital, $2 more than we can afford, in the mines. Said, but they left in good relation, they did a good job. They said, can I come back yes, you can come back when you're not happy with them. So I feel good that they want to come back. But this is the toughest it's been at Fort Baird with our CNA population. We have a larger group.
Right.
We're getting fewer applicants, and some of our older groups are leaving. So
Hopefully, Jeremy, I know coming from a nursing home in the area there, maybe he'll get lucky and have some people follow him or something.
We've been trying to email him and get in contact with him to kind of steal some nurses and
Take some people with
take
him.
some people with him that he feels comfortable with. And we've talked about that before. Okay, and we still are working with Fort Baird, the old buildings, just basically checking on them. Clinical emergency preparedness. We have been stealing information from New Mexico State Veterans Home and implemented a clinical emergency preparedness area, which includes mock code drills. We finally did a mock code drill on the 20th Yes, and that'll be done, one per shift per quarter. And we'll do more right now because basically they're not used to it. This is foreign to them. They're excited about it. So I'm glad that they're getting that. We got we got 3 new crash carts. They're very well stocked and they're nice. They're very good. You'll be impressed when you see them.
Nice.
Yeah. So we're getting ready for that. The new portable AEDs that we have, and we're just waiting for a certificate so that we can use those. Environment of care safety. We continue with the EOC rounds through the departments. Our nursing staff is now getting involved with that. That's new, and that's going to help us out also with the care around the facility. Events, we had a tremendous amount of events. Everybody came. There was Thanksgiving. We had baskets for Thanksgiving for our staff. Christmas, we had baskets for the staff for Christmas. The residents had party after party after party. There was tap dancers and elf costumes. You gotta go and see it sometimes. It is just fun to be around there during the holidays. I try to send the safety officer away for 2 weeks, but he keeps staying there. But he watches us to make sure our decorations are safe and all that. But humbug on safety. Yeah. Medical staff report. Basically, we are doing great with our medical staff there. There's nothing that we're worried about there. Our psychiatric services are split between 2 psychiatrists, and they're very pleasant people, and we're glad to have them at the facility. We also continue to participate in the UNN Echo Dementia Clinics. So thank you for having that out there. Infection prevention, as we've all said, the neurovirus attacked us pretty well. We had, if my memory serves right, about 62 residents and 61 staff members that contracted it. And dealing with the different groups around the state, they gave us a lot of help and information. And they told us, they're over with it. Then they have to stay out for 3 days. And we just kind of put a closure down saying, only if you need to come in, come in.
Right, it was very bad.
But it went through quickly, and Dr. Guista always makes jokes about in and out and things like that. He enjoys this tremendously. So, but he's fun to work with.
You guys did a good job in controlling that.
Oh, yes, very good.
I guess he wouldn't be joking if he had it, though.
Yeah. It was funny, but we kept on worrying about our staff. Why is there so many staff? Because at the Veterans Home, they didn't have that many staff. And we kind of came to the conclusion it was our new Kronos machines, where people are putting their finger on there. So we put in a new cleaning procedure on that. And it seemed to have stopped immediately. I don't know.
That's very weird.
Yeah. I don't know if that kept it going, but it might have been. Because, yeah. We're very proud of our influenza vaccinations. We have 95% for employees and 96% for residents. And so we're doing very well, but we continue to try to make it 100%.
I think Donna just hit a couple things on the next page here. We'll because we're
Sure. Information technology, basically, we're working on different aspects in there. On the 23rd, we're receiving, Jeff is coming down to the place, Fort Bear, to look at,
Jeff Escobar?
yes,
Good.
for Avatar, CWS. So it'll be good to have Fort Bear with an electronic group. CDU is doing great. We did actually put in the new counselor. We have a new counselor and we have a new director. So, well, our old director, our old counselor is our new director. So CDU is getting pretty well established. And if you have any other questions for me, I'll take them. Thank you very much.
And let me go back. I guess I'm going to make a motion, or request a motion, to approve all 7 administrative reports as a group.
So moved.
Second? All in favor?
Aye.
Opposed? Okay, motion passes unanimously. And then I know Rick's been sitting there patiently waiting to give his Program Area 6 financial report. So thanks for being here today, Rick. And that would be on the next page, right after Fort Bayard. So, Rick, you want to go ahead and do that? This would be, I guess, through November, I guess, right?
Yeah, we had about Dixon Orchards.
So I have Keith. Thank you for being here. Sure, go ahead, Rick.
On the fiscal piece of this, we're still on the audit completed on time, but we still don't have an official audit report. Probably won't receive it until I'm thinking maybe the next couple of weeks. So these numbers at this point are still not numbers, so we're affecting a little bit in the red, which actually isn't too bad. For 13, we're actually a little bit to the good, about 200,000 as well. If you notice though, now this year, I guess it sounded like this is a common theme amongst most of the reports you guys are presenting, but we've done VARs in the amount of $4 million already out of the salary and benefits. And I know the LLC actually, I think it was actually a representative that was asking about, he wanted a detail of what we did in FY12, and I think the FY12 we did almost $5 million out of salary and benefits, and I know, so I guess the thing we need to do is, I don't know, a lot of your hands, but we need to concentrate on hiring people, so we don't have to depend on contract workers, like you already stated, contractors costs are a little more expensive than salary.
Right.
So.
For many, many reasons, we need to just keep hiring. You know, we all agree on that one.
Yes.
Absolutely.
So I'm pretty sure they may be looking at this closely again for fiscal year 13. And especially when they get the reversion numbers, they're going to be looking at this.
Yeah, absolutely.
So the thing is, although we took out $4 million out of the salary benefits, we're still projecting $4.1 million to the good. However, we don't have a revenue to sustain that amount anyway. If you take a look at the revenues and the other revenues group, at this point we're projecting $4.6 million in the red. So even we still can't hire everybody, and as we expect to. See, we have that vacancy factor, not rate, but that vacancy factor, where it's built in, right? I'm not sure what we are here in Program Area 6, but we can't fill all of them.
Right.
So, one thing I wanted to mention was thank all of your fiscal people and you guys for assisting the audit. I can't give any details right now, but I can say it went well. There were a few findings, but I think we can hopefully address them this fiscal year.
Yeah.
And I'm not sure they're related to this program area.
I don't think so either. I think that's good. Rick, after the meeting, I guess it sounds like, I know we had a quick turnaround with getting some information back to Ruby Ann this morning, which sounds like you guys, I know Eileen was burning the midnight oil last night, doing some of
We
that.
got the LFC, the distribution sheets, but we may be getting the LFC recommendation tomorrow.
Right. It's just
Hopefully
something.
it's tomorrow.
Yeah, you know, we'll sit down and chew on that as a group. It was, and you know, it is what it is. It could be worse, but I think we were expecting a lot of it. They did, but we'll sit down, and I didn't get a chance to talk with you guys this morning because it had a quick turnaround time. But I think we got something back to her. We're getting.
It's been Philip sent them about 20 minutes ago.
Okay. So that was hard because we just got it yesterday, right?
We got it yesterday after 5 o'clock.
Yeah. And they said they wanted it back this morning. I guess they didn't actually want us to review it or something.
That's a shorter timeline than you give us, bro.
Right.
So I stand for any questions.
All right, and well, let me make a requested motion to approve the program area 6 financials.
So moved.
Second,
Second.
all in favor? Opposed? Okay, motion passes unanimously. Now, I forgot earlier, it's probably a little late to mention it now, but Kathy had brought some coffee and snacks there, but they're still there, but I guess we should have mentioned that, right? All right.
I'm sure everybody's hungry now.
Thank you.
Thank you, Kat.
We have a few more items, and as we go back over, we were talking at the beginning of the meeting with the credentialing. I don't know if we have any approval of policies today.
No problem.
So we'll pass on that one. But we are going through a major, I guess, revamping, rethinking how we do credentialing, revamping of the lineup. We had a group in here yesterday that I think will be the new membership of the credentialing committee, which would be separate from the quality review team that Louis works with. So they're two separate groups. And we need to continue. Credentialing is essential to this group because we need to make sure that we're going through that process with our regulatory agencies and showing them that we're credentialing and re-credentialing and making sure that we're providing safe care. So did you want to comment a little bit about that? I mean,
Yeah, because we should, before we didn't have enough physicians on the credentialing committee, and now we've got majority physicians on the credentialing committee, so it's meeting all the requirements that we really needed to do.
I know,
So
Gabrielle, that's a work in progress, I think, in the bylaws.
Part of our problem with our policy is we always had the horse, or the cart before the horse. Now we're getting our bylaws set down, and so when we get the bylaws, then we can make this committee permanent instead of temporary.
I know you did do some credentialing yesterday,
Yes, we have.
and that's what this report is, I think, right? You had some
Yes.
recommendations to make to the board today?
Sure. We'll go through these. We go by departments. Public Health Department, there was two of them. There was Barbara Clark as a nurse practitioner and Elizabeth Martinez, an MD. Both were approved by the Credentials Committee. Do you want to do it as a group, or do you want to do it
I think we can do it as a group.
in mass? Okay. Second one is from Sequoia's Matthew. Where's Matt? Oh, he's a dentist. That's right. I'm sorry.
That's not.
That's veterans.
That's
home.
Veterans Home, excuse me, all right. The third is for Rehab Center. It was a nurse practitioner.
I know that name from the past.
Mine too.
From Sequoia, we had a dentist and a social worker, both approved. From NMDOH, we had one psychologist, 3 psychiatrists, and 1 nurse practitioner. The nurse practitioner, I'll explain, you'll see it says temporary 120-day. That is not really true, it's actually a reappointment. This young lady had some problems. She was being monitored closely, and for the last 3 months she has had really extensive monitoring by the staff over there, and came back with good reports. So we're planning to keep her, extend her privileges, and we're going to keep her on monitoring for another 6 months. So we approved her. So as a group, the Credential Committee approved all these people on this thing.
Make a motion to
Right. So on that last one, it says temporary or 120-day emergency
No,
privileges.
that's
for now.
reappointment.
change your X.
All right. Okay, great. Let me, first, are there any questions about any of those with anyone? Now, let me make request a motion to approve en masse, all of the credentialing as a group.
So moved.
Second, please.
Second.
All in favor?
Aye.
All opposed? Okay, motion passes unanimously. And I guess in terms of the last couple items here, our next meeting will be in April. I don't know a specific day or time yet, or location. We're usually in the middle of the month, and I guess I'll have to give that some thought about whether we want to do it here again or at one of our facilities. We got a little bit of time to think about that. I don't know if we have any. Well, we don't have Ruby Ann here today or Pam.
No, it's nice and quiet out there.
Okay, so we don't have any comments from the public. And I'm not sure, even with an adjournment to close executive session, I think we talked about pretty much everything I'm guessing we wanted to talk about today. Does anybody have a desire to adjourn to close executive session today?
Come on, we got at least a couple more hours to
Right.
consider it.
If not, then we won't adjourn to close executive session today. And instead, I'll ask for a, sure, go ahead.
I was a little sort of set back this quarter, trying to get the data out, the report that you wanted. I think I had sent an email out to the rest of the administrators to kind of figure out what we need to put in there. And I'm not concerned, but I'd like to figure out if there's a way for us to be sort of uniform so that.
Sure.
What I don't want to do is go out on a limb and put something that we shouldn't put, but maybe if we stand.
Well, I think the ones today were good. They were good.
I had actually added some demographic data that I included in the past, but I didn't pass it out
Right.
because they hadn't been approved.
I think when we are in closed session, as we're developing what we want to do in there primarily is look at the clinical dashboard that we're creating. We want to be able to say, we need to do that. Most of our meetings, we need to be spending the time looking at the clinical data and looking for trends.
And I have that as well, but I
Right.
didn't bring that at all.
No, I think it's time to, because of the,
Hopefully, Brad, for our next meeting on the 23rd, with the quality review team, we will have a prototype of that report of the clinical indicators. And then we'll also, I just wrote a note to Gail while we were looking at these, that we need to standardize the format for the actual report. And that also has to do with the governing body bylaws that we're just sketching out, that outline what it is that we need to put in these reports. So hopefully by the next meeting, we'll have an understanding, a clear understanding on how the data dashboards are going to be set up in each facility, and then the requirements for the reports for governing body.
But you're satisfied with the reports the way they came in, Brad? I guess we can do that again.
yeah, but you're also right that what we need to do, we're required to do, and regulatory agencies like Joint Commission and others would want us to do is use our time in closed session to, really look at some of those more, confidential clinical data.
Yes.
In each facility, and also trending it across that. So that's a very important component that we want to be doing in closed session. But I don't think we'll have the need to do that today, but we want that to be a major part of what we do. Absolutely.
Okay.
And I don't know if there's anybody else that has anything for me to sign also, but I know Troy gave me on the credentialing. If anybody else has anything that I need to sign on their credentialing, just let me sign that for you.
And I had one follow-up question just for the administrator. We're doing some evacuation training and changing some of that on our plan. And I wanted to know, when do any of you have something set up for when we do sort of we do a mock and we send people out. A lot of times for the patients that can't really get out of the facility, we pay special attention, and we don't actually take them out of the facility just for a mock. But my question is during the cold weather, we have some of these folks that are fragile. We've talked about maybe even housing them in the vans, for instance, if it becomes a long-term situation longer than a 15-minute evacuation. And I didn't know if you guys had something written, or is there something in your plan that you could share with us so that we wouldn't have to go back and recreate the wheel. But I thought we're smaller, so we don't have as many patients to deal with. But now that we're adding adolescents, I'm a little more concerned because it's going to be a little more difficult to maneuver outside. And again, it always comes up when the emergency, one of the buttons is pulled, and we have to take people out at midnight, in January when it's 20 below, 20 degrees, and it's a little frustrating. So I was wondering if you guys had anything or had any ideas. I thought I'd just throw it around the room. You could forward to me. It doesn't have to be a discussion now, but I don't want to hold everybody up. But I thought it was worth putting it out there.
I think every facility has an evacuation plan, and we should have.
Right.
Yeah.
In regards to mocks, we don't actually move the patients out. We don't do that. A lot of ours is contained within, so if you have a fire or something that happens over here, we try to move them to
Well,
another.
that might be your answer right there.
I think it's gonna depend on how you're zoned, and there's some odd configurations in some of the buildings. Sequoia, for example, we don't have, even though we have all of these different buildings, everything is zoned as one building. And so we wind up if something, as opposed to evacuating the administrative section, which is where your fire would be, it doesn't work that way. And so it would take considerable expenditure to do that. So I think that's really where your starting point is to see, because I would think that's an old hospital. So, but it was built as a hospital, so it might have different zones, which would help you.
And I think we're trying to coordinate with the county as well, so I think that goes into our evacuation.
Yeah, we can avoid taking them outside, we could.
Inspection, the annual fire marshal inspection, they'll ask for those plans, they'll look at them.
Yeah, we have.
They'll wanna see.
I just don't know what we do long-term in reference to.
Okay.
I know, long-term, we take them to Sequoia, that's our backup plan, really
Yeah.
is.
We take ours to Fort Perry.
Come on over, got
No.
plenty of room.
We had MOAs and stuff like that in place with.
So you can take it somewhere else.
Different buses and transportations and gas companies.
Thank you.
All 911.
We'll send
Take vacation soon, your annual leave for me.
We're discharging if they walk out the door.
Right. Now, one other item, that vehicle in Roswell, we're gonna try to get that to Lori, I think, right?
It's sitting out in front of the building right now.
Is it really?
Well, we went over to pick it up and it wasn't running.
Yeah.
So we contracted with a local company there in Roswell to get it fixed. So we have it fixed now, and so my staff is going over on Tuesday to pick it up.
It's got almost no mileage, very little mileage.
Right.
2000.
Right, because we're taking 20 veterans down to the basketball game in Cruces, so I need that van for the
Wow.
following Saturdays.
Great.
Greg, can I just ask you, more probably for the administrators and even for you, I know the Department of Transportation has an employee helping, or an employee for employees group that they have, and actually, and so you get membership in that as a employee member, and you donate, or it comes actually automatic withdrawal out of their checks. It's about 50 cents a pay period, I think is what the Department of Transportation does. And then if there's a death of a member, like a staff member, that committee sends $100 to the family.
Oh, really?
You can set up anything you want, but then they also have ways to, if there's a death, you can send flowers, whatever the committee wants to put together.
Right, I like
And
that.
I have interested staff in it because they can use it for their Christmas party. And I have a group of staff, actually a lot of staff that are interested in trying to set that up in DOH. Is that something
Sure.
that we could
Yep,
model
and,
after the Department?
well, if you send that, like the employee recognition program that we're in the process of launching for 2013 is, we took that basically from Department of Transportation. So that's something, I think Regina, one of our new team members in administration up there in the secretarial side, has worked there, so she would be familiar with that also. Maybe you could just send that to Kevin Griego, that idea.
Okay.
We can discuss it.
Well,
That's a
I have
great
a committee
idea.
already ready to go, and they want to put it together and get the recommendations. We'll send that up to.
Yeah, what we'd have to do is just learn more, and Teresa would, how they're doing that in Department of Transportation. The good news is, if they're doing it, then
Right.
anybody else can do it too.
That's what I was thinking.
As long as another state agency is doing it, we have the ability to do it as well. Okay, that's a good idea. I like that idea. Okay, well, let me go ahead and then request a motion to adjourn.
Oh, one more thing, Brad.
Sure.
Next meeting? Next governing board?
Yeah, I don't have an exact date in April. It'll be in April.
April? If we keep it on the second Wednesday, it will be
Second.
the 10th.
Yeah, well, we could say tentatively.
Yeah, 10th.
It'll be the 10th. We could just say tentatively April the 10th here at SLD, but we're subject to change. I think Easter, that holiday is the end of March, 1st of April, I think, this year. Okay. All right. So let's see, I had a motion to adjourn, and I know you guys don't want to, but if you ask me for it.
I'll make a motion.
I'll second the motion.
Okay, all in favor?
Aye.
All opposed? Okay, thank you. Motion passes unanimously, and thanks. There was a lot of great information sharing today, which I appreciate very much.